Good evening, everyone. Thank you, Dr. Ace, for the introduction and the warm words of welcome. It's really appreciated. It is quite daunting when you say that the number of people and the vast the variety of people that are attending this conference or this webinar. It is pleasing that there is such an interest in ADHD. Uh, I also would like to say that, our topic today is important, but we don't intend to provide an overall view of ADHD, but we're trying to focus a little bit on some of the issues which have come to the fore, which is the question of whether ADHD is overdiagnosed and undertreated. I find, I must admit at this point before we move on, is that this format is, although it is an excellent format and it allows many people to participate, it can be quite difficult when you're not in contact with the audience and you're not sure how you're being received. And as psychiatrists, and health professionals, we want that feedback from the people and to look at the body language. But I hope to do justice and to try to give you some information with regard to this topic. Next slide, please. So briefly, as what we're going to do is we'll just briefly discuss the clinical characteristics of ADHD for those that don't know some of the diagnostic criteria, etc. Then we'll move into the issue of whether this illness is overdiagnosed, and then the question of undertreated. And finally, we'll end with some points as a summary and some take-home messages which hopefully you find beneficial in your practices or in dealing with the people that have this problem, people and their families. So, in a nutshell, ADHD is characterized by a cluster of symptoms made up of symptoms associated with hyperactivity, as you're all aware, and then it's inattention, and then impulsivity. Now, the diagnosis is a clinical diagnosis. Clearly, it's not, there are no tests, laboratory tests or special tests that enable a clinician to diagnose it. But unless one wants to exclude comorbid illnesses, in which case tests can be done. It is important that to note that the DSM-5, when it was reviewed, has updated its criteria. It's updated its criteria for ADHD to encompass the full lifespan experience of an individual. Previously, it was thought that ADHD was just a disorder of childhood, and as we've gone along, we found that it does occur in adults, and sometimes from childhood it continues into adulthood. Next, please. Okay, so what does the DSM-5 say? There are a few criteria which needed to be fulfilled in order for the diagnosis to be made. It is important that there is a persistent pattern of inattention or hyperactivity, impulsivity, as characterized by the symptoms that we're going to describe. As far as inattention is concerned, the DSM-5 requires that there must be 6 or more of the following symptoms, which must be present for a child aged up to 16 years. And if they're older than that, then 5 or more symptoms are required. The symptoms include a difficulty in maintaining attention. They fail to pay close attention to detail. Organizing activities and tasks seem to be a challenge. They lose things crucial to a certain task or activity. Often have a diverted attention by extraneous stimuli, as you know, that they are there in the room or in that work, and their attention is somewhere else, and they're quite forgetful in their daily tasks. So these are some of the causes. When it comes to hyperactivity and impulsivity, once again, DSM-5 requires 6 or more of the following symptoms under the age of 16, and then 5 or more for the age of 17. So what are some of these hyperactivity symptoms or impulsivity? It's excessive talking or physical movement. There is impatience, answering the questions before the question has ended. They're very fidgety, unable to sit still. Their impulsive urges is to move around all the time, and they tend to interrupt conversations or speaking out of turn. Now, combined with this, DSM-5 says that several of these symptoms must show up before the age of 12 years. So it's when these symptoms occur beyond the age of 12, or if they're not there present before the age of 12, the question of the diagnosis is in question. And most important, the symptoms must be present in two or more settings: at home, at school, with friends or relatives, or any other activity. There must be clear evidence that the symptoms affect the quality of social, academic, or occupational function. Now, this is an important criteria when you come to DSM-5. As you're aware, with all psychiatric disorders, there are many symptoms which can occur, but they do not affect their functioning. So this is important. It must affect their functioning. And finally, the symptoms cannot be explained by another mental disorders, such as a psychotic or a psychiatric disorder, and also from substance intoxication or withdrawal. What is important to note is the symptoms vary according to the age. Clearly, some of the inattention symptoms in preschool years, it manifests itself as short play sequences, leaving activities incomplete. As they move into the primary school, they're forgetful, disorganized, and distracted. Into adolescence, we find that there's a lack of focus on the details of tasks, poor planning. And then when we get into adult, we find that appointments are forgotten, there's lack of foresight, details are not completed. And similarly with hyperactivity, you can see that the symptoms vary according to the age and according to severity of that symptom. So while the child might appear like a whirlwind, I hate the thing as parents will describe it, the adult is more restless. He expressed subjective feelings of restlessness rather than running around at work like a kid that's hyperactive. Impulsivity, similar cases occurs, and in children they tend not to listen. They don't have sense of danger, and as we progress to adulthood, we find that they are impatient and they make premature and unwise decisions. Next. So as we're aware, there's a spectrum of symptoms depending on the age. Similarly, there's a spectrum of the types of ADHD. We do not find all ADHD presenting the same way. There are basically three types of ADHDs that exist. One is the combined. In the combined, we find both the inattention and the hyperactivity and impulsivity symptoms present almost equally. Then there's a predominantly inattentive presentation where more inattention but less hyperactivity and impulsivity symptoms. And at the other spectrum, we find predominantly hyperactive impulsive presentations where there's more hyperactivity and impulsivity but fewer inattention symptoms. And this thing, predominantly hyperactivities are the ones that usually manifest more often and are more difficult for the parents to cope with and for teachers to cope with. There is also a specifier in DSM-5 in according to the severity of the illness, which can range from mild, moderate to severe. The severe one is where many symptoms exist in excess of those required to make the diagnosis, and they particularly cause marked impairment in social or occupational functioning. Mild severity is usually there's few, if any, symptoms in excess of those that are required for the diagnosis, and the symptoms results in a minor impairment in social and occupation. And then you've got in between the mild and severe, the moderate type of moderate severity. Next. So the question comes now to, is ADHD overdiagnosed? When we look at the prevalence of ADHD, it has increased over the last decade. The Center for Disease Control shows that the number of children aged between 3 and 7 who receive a diagnosis of ADHD has risen from 5.5% in 1997 to 9.8% in 2018. A recent review of over 300 studies showed that 96% of the studies confirmed continuously increasing ADHD diagnosis. Now, the prevalence of ADHD does not significantly differ between Africa and South Africa and the rest of the world. So it would appear that, as is the rest of the world, the prevalence in South Africa is also increasing as far as. Now, the question is this prevalence concerning that the rate of diagnosis of ADHD is increasing? Next slide. So there is a lot of debate about this increased prevalence. Is this a true increase in frequency, where suddenly now there are more people, more distinct people who are suffering from ADHD? Is this because there's an improvement in the detection? People are more aware of it. Parents are more aware. The social media, which allows for focus on that, the various interest groups that tend to, and the teachers are more aware of it. But most important is, the question is, are we overdiagnosing ADHD? Is it that we finding that most of this increase is because increase in prevalence is because there's a tendency to overdiagnose? Next. Now, overdiagnosis is controversial, and it is very hard to measure. There have been numerous publications, and as this indicated, in a review in 2021, to all these numerous over 300 publications, they concluded at the end that there is evidence to support overdiagnosis. But the overdiagnosis is especially in children and teenagers with mild symptoms. So there is a tendency that where the symptoms are mild and they do not quite meet the criteria, there's a tendency for the clinician to diagnose ADHD. However, local researchers and experts state that while ADHD may be overdiagnosed in the rest of the world, they believe in South Africa it is more likely underdiagnosed because there's a shortage of resources. It is frequently unrecognized. Children are usually seen as naughty kids. Individuals and parents interpret the symptoms as part of their personality, and they're also unlikely to seek medical attention unless the behavior is associated with severe impairment of function and it is noticed by others, like academic failure. So there is evidence to support that is overdiagnosis. So what's the problem with overdiagnosis? Is it a serious problem? There are researchers who feel and who said that there is a possible that we are going to stigmatize normal developmental behaviors. We're going to create an identity that enhances prejudice and judgment. So people are, the kids in the school, adults are saying, oh, well, you have a diagnosis of ADHD, and which is expected for you to be slow and to be performing and to have these problems when it comes to achieving. And these feelings create feelings of these consequences in isolation, exclusion, and shame. And we know some of these is, are going to affect the psychology of the child and the adult. It results in disempowerment also. We find that the decrease in responsibility by all, by being given a diagnosis, suddenly it's now, well, all my problems are because of this diagnosis. So therefore, I don't need to do anything. End result is inaction, stagnation, as well as promoting hopelessness and passiveness. The sufferer, the person diagnosed, tends to not play a big role in trying to recover or to improve their symptoms. So there are consequences for overdiagnosing. Next. Now, why? Why do we think there is that we are overdiagnosing ADHD? The first thing is that people thought that maybe it's the review of the DSM-5 criteria and the so-called diagnostic inflation. As you're aware, in other disorders, and just a case in point that many people are aware of, that and something that I noticed that, suddenly in the general medical field, it seems like 90% of the population suffers from low vitamin D levels. And you ask yourself, how is it suddenly everyone's got low vitamin D levels? And then you look at it and you say, well, maybe they lowered the threshold for vitamin D, levels in laboratory testing. So that's a question of diagnostic inflation. Define the definition to include ambiguous or mild symptoms, or making behavior which previously would have been considered normal as being abnormal, now considered as being normal. So it's that whole criteria, and there have been criticism around DSM-5 that maybe they've included too many symptoms that possibly might be a normal child, and that could cause the overdiagnosis. As far as misdiagnosis, again, that is possible. Diagnosis may be difficult to make at times. Uh, we know that the symptoms of ADHD usually mimic other conditions, such as learning disabilities and anxiety and neurodevelopmental problems, such as sensory processing disorders. So if a child is not assessed or an adult is not assessed properly and adequately, it is possible that you may misdiagnose these and miss the problem of other illnesses. There is also increased awareness. Increased awareness, as I mentioned earlier, because of the social media, because of the education which is being psychoeducation which is being pushed by healthcare professionals, and the early detection of illness. So this might cause parents, caregivers, and health profession to look for some symptoms where they might not be there, and then that might be putting pressure on people on clinicians to diagnose. There is also pressure from the educational system. Uh, Many years ago, children in preschool had fewer activities. They played, ate, and slept. Nowadays, children of the same age are expected to read and learn. This is putting pressure on the children. And sometimes they may not make the grade, and it is perceived as they have a difficulty in attention. Children who are younger than their grade level peers, sometimes you find that they are young children who enter school in early stages, and they may not be the same age as their peers. They are less developmentally mature, and this relative immaturity can result in behavioral symptoms which might appear like the symptoms of ADHD, when in fact they're due to just simply age. Next. These overall general stress levels are very high. As you're all aware, there are many, many reasons, both for children and parents. As far as children are concerned, we know that there's, the pressure from the educational system. For the parents, the whole general state of the country, the way we are, the crime, the violence, the unemployment, etc., plus a lot of stress on parents, which then manifests onto the children. And there is a proposal that some of these stress-related symptoms may suggest ADHD, and when in fact it's simply the child or the adult's coping mechanism to deal with the stress, which might be misinterpreted as symptoms of ADHD. Once again, there's a problem of ineffective parenting practices. Parents are not very good. They don't have the time in terms of managing behavior. And this poor behavior in the child can easily be interpreted as ADHD symptoms. One of the other things we believe is that the pressure from the schools and the parents on doctors. This is important. Parents bring their children in and they push the doctors to make a diagnosis and to start treatment immediately. We're all aware of how parents can be very convincing and very demanding when it comes to what that their child is unwell and that has a medical problem, when in fact you try to tell them, no, this is just a behavior, or it's mild symptoms and it doesn't require a diagnosis to be made at that stage. And finally, the researchers believe that sometimes children are fabricating their symptoms. We find this commonly in children and teenagers who, through their communication with their peers, believe that ADHD stimulant drugs are good, are useful to get good grades and admission to well-known universities. They help you tend to concentrate and focus, and this pressure sometimes they fabricate the symptoms of ADHD. So it is clear that it would appear that there is a overdiagnosis of ADHD. It would also appear that there are some reasons that might be influencing this overdiagnosis. So, what about the treatment of ADHD? We want to ask the question, is ADHD undertreated? Next slide. So I'm just going to briefly touch on what is the treatment for ADHD. It is the cornerstone of the treatment is medication based, and the other important treatment is non-medication based. This thing. Let's move to the next slide. Okay, I've just put a link here. This is a guidelines to the, for those that want to look it up later on, the guidelines to the South African guidelines for the management of ADHD in adults and children, and it might be a useful link to go to in the future. So what are the medication-based treatments? Everyone is familiar with the stimulant drugs or the psychostimulants. We've got the methylphenidates, which include Ritalin, Concerta, and other generic equivalents. We've got amphetamines, which is the Vyvanse, sorry. Many trials have been done and all consistently show that stimulants are more effective than placebo. So they work, there's no question about it. They're available in short-acting, long-acting, sustained release, and as you're all aware, the reasons for these various dosing schedules relates to the child going to school, the difficulty of taking the short-acting ones at school. So all of these have been work well. They're there to make it easy for the child or the adult to take the medication and to continue to function and to not be dependent on the system to provide them with the medication. So the long-acting and the sustained release is one dose in the morning and is effective throughout the whole day. It also results in an increased adherence. However, they are more expensive, which limits their use. Next. This is just there. We're not going to deliver too long, but to give you an idea of the two psychostimulants that are there, the various duration of type of this in short-acting, intermediate, some of the the brand names that are available, the dosing schedule, and the approximate duration of action, and the maximum dose that they should be taking. As you can see quite clearly here that the extended release makes for daily use quite easy, and the short actings have to be taken more often. They clearly have a shorter half-life. Action is quick and similarly with the amphetamines. So this is just there for you to, when you are administering the drugs, you can take note of the different dosing schedules and what would be the, but most important from this slide that I want you to take home is to be aware of the maximum daily dose. There has been a tendency from our that it is an overdosing, and many clinicians are exceeding the maximum dose of the amphetamines to try and get better effect, when in fact all it does is it increases the side effect profile. Next slide. Other medications you're familiar is atomoxetine or Strattera. It's a second-line drug that is available in South Africa. Its mechanism of action, it's a serotonin and noradrenergic receptor inhibitor. It causes secondary increase in dopamine levels. It has a slower action, slower onset of action than the stimulants. The starting dose is usually about 0.5 milligrams per kilogram per day for 7 days, and then you gradually titrate it up to a maximum of 1.2 kilograms per day in single or divided dose. It is a good option for children who do not respond to or tolerate stimulants, when stimulants are also contraindicated for comorbidity or medical physical illness, and where stimulant diversion is a problem. We'll talk about stimulant diversion later. Uh, the side effects are severe but very rare side effects that you need to be aware of, as far as Strattera or atomoxetine is concerned, is that it is hepatotoxic and it can result in emergent suicidal behavior, both suicidal ideation and attempts. So when using this drug, you need to be take note of that and be aware of that. Other drugs that have been used is the alpha-2 agonist. The one that's available in South Africa is clonidine. There have been many clinicians who prescribed and recommendations for the use of antidepressants, the tricyclic antidepressants. Imipramine and desipramine are more effective. You've got venlafaxine and bupropion. Antidepressants tend to be used where there is a mood or comorbid mood disorder, and it is beneficial there. The atypical antipsychotics, there is no evidence to support its use for ADHD symptoms. However, risperidone has been used, and it may be useful in reducing severe coexistent aggression and agitation. As an antipsychotic, it used to be used with caution, and it must be aware of the side effects of this drug must be monitored carefully in these children. Next. Non-medication based treatment. Now, we know medication can improve the attention span of the child. However, non-medication based improves impairments in daily function, the other impairments in doing. It almost always involves parents and teachers as well as the child. So what are some of those non-medication based treatment? It's psychoeducation. I think it's important right at the outset that the more the family and the patient are aware and understand what the disorder is, the better they will be able to cope, the more compliant they will be with the treatment prescribed. So patients and their families must understand what ADHD, they must understand the benefits and risks, such as side effects of medication. They must manage barriers to treatment, and clinicians should contact and educate school teachers. Much of the child's time is spent in the school, so it's important that we educate teachers about how to manage the symptoms of ADHD. Behavior changing strategies. We need to educate and to train the parents in how to manage behavior. Whilst medication is important, sometimes it is behavior management is the way to go in order to control some of the behaviors that is associated, especially with the impulsive hyperactive type. They need to set limits, rules, reward positive behavior, and positive reinforcement of prosocial behavior. We don't want them withdrawing and isolating, and the creation of a consistent routine. One of the other strategies is stress and anger management, which might help to control impulsive behaviors. Educational intervention is absolutely vital and important. There needs to be interventions in the classroom. The child spends much of his time in the school, in that environment. The teachers need to be able to create individual behavior interventions. The school needs to be supported, and the school environment, and also provided with support with regard to behavior management. Next. There is much benefit and in terms of relaxation. Obviously, this is more likely to be for the adult and this thing. However, in teenagers, relaxation techniques can be useful. We're talking here about meditation, yoga, mindfulness. Regular exercise, like in all other disorders, all other is important. It helps you to control your stress levels, helps you to deal with some of your frustration and angers, and it can be very therapeutic. Psychotherapy often is required for when there is a low self-esteem, when the children feel or the adult has feelings of embarrassment and shame. It helps the parents and the siblings cope with the stress of living with someone who has ADHD. ADHD can be very disruptive in a household, and the families are also affected, and they might require therapy. For adults, we talk about therapy for marriage and family therapy, uh, behavioral coaching, for organizing the home and the work environment, structuring the day, prioritizing tasks, managing money, developing better organizational skills, and learning to manage your time efficiently. Now, one might think that all of these might get addressed by the use of medication, but it's usually that so much of this is learned behavior, and it would require therapy to try and overcome this and to retrain the individual with regard to that. As far as complementary and alternative medicines, chelation therapy and dietary modifications such as increasing the intake of omega-3 fatties have been shown to improve some of the symptoms of ADHD, and might be something as to treat the patient with as in conjunction with other modalities. Next. Now, most of the academics and researchers recommend behavior therapy and medication, preferably both together for children under 6 years of age and older. And for children under 6 years of age, behavior therapy is recommended as the first line of treatment. Obviously, the reasons are there because we want to try and avoid medication in these children as far as possible and until only when absolutely necessary. Next. There is no doubt that treatment can improve the lives of the people with ADHD, and I emphasize here that it must be appropriate treatment. It provides a explanation, a biomedical explanation for the problems and for the symptoms that are experienced. It supports a sense of legitimacy, uh, accompanied by understanding and sympathy, as well as decreased guilt and blame. And I feel that enablement is often experienced, and this is characterized by increased support and by enhanced ability to seek and accept help. So the diagnosis is useful, the treatment is useful, and it gives them a sense of that their lives can improve. Next. Next slide. Okay. Pharmacotherapy is recommended because it obviously and clearly provides improvements in the core symptoms of ADHD, including hyperactivity, inattention, and impulsivity. However, the leading academics feel that prescribing medication is not considered the first option internationally. Medication typically does very little to help the symptoms of disorganization, poor time management, which are the very issues that cause the most problems for many people with ADHD. And there is unanimous consensus that medication for ADHD is more effective when it is combined with other treatment modalities, such as therapy. So, despite these recommendations, there have been a substantial increase in pharmacological treatment for ADHD. The National Parent Survey reported in children from the ages of 2 to 17 with current ADHD that 62% of these children were taking medication. About 3 in 4 children receive some type of treatment, but only 32% receive the combination of medication and behavioral treatment. The Attention Deficit and Hyperactivity Support Group of Southern Africa also reported in 2014 that South Africa is one of the highest rates of prescribing medication for ADHD. Although I haven't done, research in a proper research in this, I worked in the Johannesburg Health District, which is provides medication for a lot of the kids who are on ADHD and who can't afford private care. And we found that over the years, the the amount of medication that has been prescribed has substantially risen in in our district to the point where ADHD is one of the psychostimulants is one of the highest cost drivers for as far as medication, and this is concerning. Next. So why would we prefer pharmacotherapy alone? Clearly, it's a quick fix. Parents push it. Educators want it. It works very efficiently and quickly, and it's there. When practitioners and parents think about treatment for ADD, they immediately jump to psychostimulants. Many people equate ADHD with prescribing medication. Similar to other medication, there's pressure from the parents on doctors to prescribe medication. You're aware that similarly with other illnesses, for example, when a child has a flu or an influenza virus, parents won't take it when when the clinician says, no, we're not going to prescribe you antibiotics. You just need to, hydrate yourself and manage your temperature, etc. Parents don't buy that. There's a lack and a desire and ability of parents and educators to implement behavior therapy. Behavior therapy is hard work. It requires a lot of effort, a lot of time, and it's a process. It takes a long time before you get your desired results. And to do this, we also, in South Africa particularly, there's a lack of resources, and it's not easy and cheap to come by. Next. So the heavy reliance on medication has raised concerns. The concerns are they are the side effects of the medication. Now, common side effects associated with stimulants are there. However, they tend to be mild, dose dependent, and transitory. Next. There are serious side effects which are of concern, and that's the growth retardation. Stimulants may stunt the child growth. Growth resumes once the stimulants are stopped. And other options for concern about growth retardation would be switching to atomoxetine. Sudden death has been reported associated with with methylphenidate. However, there is not too much evidence that it is higher among those using methylphenidate than in the general population. Although the risk cannot be ruled out, the absolute magnitude of such a risk is very low. Next. The abuse and diversion is an important one because all stimulant medications have a potential for abuse. Abuse and diversion, the selling of the medication, giving it to the friends, having it stolen has increased in the recent years. Abusers often report using stimulants to increase their academic performance and also for recreational use. Misuse is common, especially among those with comorbid conduct or substance use disorders. And although long-term stimulants may be less likely to be misused or diverted, atomoxetine, where they might be, the atomoxetine should rather be prescribed. Next. Okay, so what we've found is that there is increasing evidence that ADHD is being overdiagnosed and it is being undertreated. So how do we prevent overdiagnosis? Maybe that's a suggestion to the thing that we must do a complete assessment. We must obtain information from the parents and teachers, gather detailed information on peer and family relationship, medical history, etc. Assess the family environment. Is it chaotic? Are the parenting inconsistent? Is there abuse and neglect? Conduct an examination in order to exclude other diagnoses. Next. Following the assessment, the clinicians should then decide about what interventions and formulate a treatment plan integrating the different modalities that need to achieve. We need to not jump to only medication and send them home. The treatment plan should be individually tailored to each patient, constantly reviewed and updated according to the response. A close monitoring of the treatment responses is required, and it should include data from different sources, including parents, patients, teachers, etc. And in treating milder ADHD case, the benefit of pharmacotherapy should be may be considerably reduced or outweighed by them. We need to make sure that the benefits outweigh the harm in using pharmacotherapy in mild cases. Next. Now, if we have to prescribe medication, then it must be noted that every child responds differently, or everyone responds. Some people experience a dramatic improvement, while others experience little or no relief. So we need to be aware of that. Because everyone responds, find the right medication and dose takes time. They should be closely monitored for side effects, and side effects disappear. Now, this has prompted me, and I'm glad that it's there. I asked a question that if a child is diagnosed with ADHD at the age of 6 or 7 and is put on medication, and we know that the symptoms of ADHD continue into adulthood and late, the question was, do we continue with stimulant forever from the child 6 years until he's no longer functional when he retires? What is the thing? Do we discontinue medication? And there's very little in terms of that. It seems like when patients are put onto Ritalin or to a stimulant or to medication, they continue it for the rest of their life. So discontinuation, if there is no objective improvement has been observed and after the appropriate adjustment is over a 2-month period, you should consider discontinuing the medication. Do a trial of treatment. Treatment is, if the duration is also in excess of 2 years, consider it. As the child is in adolescence, particularly late adolescence, consider trial of treatment, and when there is a substantial reduction in the core ADHD symptoms. The trial of treatment should be planned and done at a time which is least disruptive to the academic and social functioning. Next. Okay, that's it. There is some reading material here, which which provides lots of details on all of this that I've discussed, especially referred to the South African Society of Psychiatrists for the management guidelines. I hope this has been able to put some light into the question and whether ADHD has been overdiagnosed and under treatment. I believe so. And I think that maybe this might be useful for you to try and prevent you reaching that particular scenario. Thank you.
Thank you, Prof. Thank you for really excellent and insight into this very, very difficult condition and to know how to manage it properly. I've noticed that there are lots of questions. I'm going to kick off with 3 that I've picked up along. The first one is there a gender preference? So, boys are naughty and then they're more easily diagnosed with ADHD. Is that true? Is it less common in females? Or is that just because we're not sensitized to it? That's my first question. The second one, there was a question on why use a stimulant when the condition is already a hyperactivity syndrome? So maybe if you can just explain that again. And then the third question that I wanted to highlight or ask is, what about adults? How does one diagnose ADHD in adults if one hasn't got the history of, their childhood and how they reacted in school? you can start with those 3 questions, then we can sort of work through the others systematically. Thank you.
Thank you. I'm not sure whether this is, but sorry, I missed the middle one. I lost you a little bit there.
The one was about girls. Are girls underdiagnosed? Yes. Then the second one was the age. What does one do with the over 40s or whatever? How do you diagnose that? And one was on the why does one use stimulants for a hyperactivity syndrome? You know, the mechanism of that. I think there was somebody that wanted clarity on that. Yeah. And I don't know.
Yeah, thank you. As far as the gender is concerned, I think that you know, the literature is and various researchers have looked at it to say, is there a gender preference in terms of the prevalence of the illness? I don't. The thing is that what they've concluded is that because the boys tend to be more disruptive and more physical, it would appear that they are more diagnosed, more identified and diagnosed more often as compared to the gender. But there is no clear evidence to say that there is a gender preference for males. However, I stand to be corrected that, you know, I mean, but that's my reading and that's what I've picked up. As far as adults is concerned, yes, it can be difficult to diagnose, especially if they have not been diagnosed in childhood. It's very easy when they move from childhood ADHD into adult ADHD, but when they have not been, that's why it's so important. And I caution people to say, you know, instead of taking this checklist, which adults come with and say, I've done the checklist and here's all the symptoms, that one needs to spend time and to look back into childhood to see whether the symptoms were there and whether they can. Sometimes it's not possible, but I think, you know, this is where, if, you know, parents are available and maybe they can inquire. So we're saying that an assessment is important before jumping to make that diagnosis and to start the treatment. But certainly, if there are enough evidence in adulthood to support a diagnosis, then by all means, the diagnosis needs to be made, because in treatment will result in a significant improvement in the functioning of that particular person. Yeah, I think that as far as the mechanism of action of stimulants, we could take a long time trying to explain the neurotransmitter basis, but it is known that stimulants have a paradoxical effect when it comes to you know, I mean, when you give a stimulant to a normal individual, it will result in that person being stimulated, a secretion of a whole lot of transmitters, dopamine, etc., and you expect them to become more hyper when they take a stimulant. However, in an adult, because of the neurotransmitters that are involved, when the stimulant is and it stimulates the dopamine and the other receptors, it causes them actually, the mechanism causes them to have less symptoms, or addresses these symptoms and resolves the problem. It could take a long time, and, you know, to try and explain this without visual aids, etc. But there is a perfectly valid explanation for why stimulants seem to be to work for hyperactivity.
Then, just linking onto that, there's another question on what is the role of the trial of treatment. I think you've really answered it, but maybe you can just
yeah. Again. I personally, I don't think you need to have a trial of treatment. It's almost like you're not sure about what you're dealing with, and you want to see, well, if I give them stimulants, then maybe the symptoms will disappear. Then I've confirmed my diagnosis. I think I'd rather, you know, work on the basis of make a complete assessment, reach a diagnosis, and then if you feel you're convinced, then you put the patient on treatment. However, after you've used this thing for a period of time and you find no improvement, then by all means you know that, listen, you've probably misdiagnosed the problem, or maybe you haven't reached the right dose. Once you've, reached the appropriate dose, tried a couple, then possibly review your diagnosis, say, you know what, maybe wasn't ADHD in the first place. But I wouldn't use medication as a trial to confirm or make a diagnosis.
Then there's a
Thank you.
question. What is the role of the educational psychologists and school nurses in terms of assessment, as kids are sent to them as for clinics to assess, and whose role is linked to that? The role of the educational psychologists and school nurses.
The school, obviously, the child spends a lot of the time in the school. I mean, the behavior in the school, the inattention, the performance will be noticed in the school. It makes sense for the educational psychologist, the nurse, the school nurse, to play a role in assisting in, and that's why it is important that when a parent, when they, that they do a proper report, that they give that information, so that when a parent takes the child to the clinician has all of this information to help him make the diagnosis. So we don't expect the educational psychologist to make a diagnosis to this thing, but to make an observation and to record what they have observed and what are the symptoms that they have picked up. And obviously, in terms of an educational psychologist, what will be useful for the clinician would be say, well, the educational psychologist is excluding a learning disorder or some other disorder that might be misdiagnosed as ADHD, when in fact those are those. So those are the role, I think, of the educational, to make sure that we don't jump to ADHD, but to look at some of these other disorders which can be in children, which can look very much like symptoms of ADHD.
Then there's a question on the occupational grounds for clients with ADHD from employment. Are there legal guidelines?
I'll be honest with you, I'm not familiar with what would be the, in terms of legal guidelines and with regard to. I do know that when we come to kids and school, there is some, concessions granted to, and that's according to the education authorities, that if a child is diagnosed and confirmed with ADHD, they are given additional time for exams, or for, in terms of sitting for exams, they're given additional time to make up and compensate them for this disability that they have. As far as adult is concerned, I'll be honest, I'm not sure whether there is anything in the Labor Act or anything to say. But I would think that, it's the same thing like any other disability. I'm sure that this is something that, will be something that can be discussed. But whether it's in the Act or not, I'm not familiar. Thank you. Sorry.
Then I don't know if this is important. They say, as a social worker, most of my patients with ADHD are later diagnosed with conduct disorder. Causes leading to this new diagnosis. Yeah. I don't know if that is relevant.
I'm not sure. I think maybe as you said, that the conduct disorder was probably not recognized, and the symptoms missed, and possibly the use of stimulants in this particular patient might aggravate the conduct disorder that exists in that child right at the outset. So one needs to be very cautious.
Yeah. Then a question about the combining of drugs in a different group, if that is done at all. And a specific question on, is Ritalin still available now in healthcare facilities in Gauteng? Excuse me.
Yes, for the second question first, Ritalin metalphenidate is available in the state sector. As you're all aware, in the state sector, the health, the economies, and this thing makes it very difficult for the health sector to provide. As I said, that I spoke for you in my district, the number of doses of Ritalin that have been prescribed have been just escalating, enormously, and it puts a big strain on the budget, the pharmaceutical budget of the department. And it means that if most of the money is, or large chunks of the money are being spent on stimulants, then there's very little of the other medication available to treat the large number of patients that also do. So whilst it is available, there are often times when there might be a short supply of it or inadequate. And sometimes we go for a period where it may not be available. But generally, it's still on the tender, it's still available, but it's erratic. The question was on the other question.
Combining of.
Yeah, combining. I think, combining, what has been noted is that people tend to combine different formulations or different dose scheduling of the same medication. So, for example, the use of Ritalin, one might combine a short acting with a long acting, so that you get depending on when you want to use it and what are the circumstances, when your attention is usually this thing is absolutely required. But there've been very little of use of a combination of say, for example, a first line and a second line drug in combination. But I'm sure there might be cases, depending on when the first line drug has been used to its maximum dose, that it showed no difference, then maybe touch of. But I don't think there are sufficient studies and research to substantiate the use of two different formulations.
Yeah, then there's some stress the fact that to avoid medication in young children, it's essential to look at nutritional research and support fatty fish. You mentioned that. Minor children, you start at 6 years, so I think we've answered that question. There was a question on how does a teacher manage children with ADHD in a big classroom. I don't think you can answer that unless you want to give it a
go. With difficulty. Yeah, it's not easy, but I'm sure that, I don't know, but if it is not, it should be part of the training of a teacher these days. As I said that, there seems to be an increased prevalence of it. There's more children for whatever reason. Maybe it's a genetic thing. Maybe it's about the toxins that are available that are there that causing pregnant women, and whatever reasons, it seems like it's more prevalent. So perhaps a concerted effort by the health department to work with educators to try and teach them how to manage behavior in the classroom. And I'm sure, like every other, that it's a skill that can be acquired and can be used in the classroom.
There's an occupational therapist that said, they could be used.
Yes, absolutely.
Especially in this sense. Yeah, absolutely.
Absolutely.
And then auto-regulated issues, how much is available in the public domain? I think you've answered that. Is ADHD common in children living with HIV?
Again, I'm sorry, I'm not familiar with that question. I can't see any reason why HIV should cause ADHD. Maybe it might aggravate some of the symptoms of ADHD if they were there, especially if the child was depressed and undiagnosed. It might be perceived as inattentive and, withdrawn. So it's possible that it can aggravate some of the symptoms, but I don't know of any association between HIV and ADHD.
Yeah, and there's a question, is there a link in adults? I don't think there is, but you can, I don't know if you know, if there is a link with bipolar. Yeah. Diet, I think that's about the time we have available. Just also to mention, a lot of people asked about the presentation. You have agreed that we can share it. So the Secretariat, Monica, and them just how it will be shared or how it will be accessible for people who attended. And I see we've reached almost 1,000 delegates or attendees, so fantastic. I think we have come to the end. We've already. So, Professor Musa, thank you very much for a very very succinct and very insightful topical discussion around ADHD. I think we all benefit in having a fresh look at it, and really the importance of making that diagnosis and really being led by the information that is available if one just explores enough and spends enough time to actually make that diagnosis. Any last final word from you, Prof, before we close down and say thank you to everybody, and sorry that we couldn't get to all the questions, but no. We will have some follow-up sessions going forward, probably only starting in January now. Next week, we've got another session on mental health. I just want to remind you about that. And anything else you wanted, just words of wisdom?
What I'd like to see, I mean, I think, you know, the symptoms of ADHD and this are common and it's easy and everyone's aware of it. The treatment also is not no rocket science. My only appeal is that, you know, I mean, that make sure, and others might make sure that when you're diagnosing it, that you know, do everything that you're available and to make that diagnosis, to be sure. And then once you decide on treatment, don't limit yourself to just medication. I think it's very important that we combine the medication with the therapy, so with the other alternatives, so that there comes a stage in the child or that adult where the medication can be taken away because they've learned sufficient skills to help them cope, if they can. Obviously, we're not saying they must, but certainly that is the target and that's the ultimate. As you said, have a treatment plan, long-term treatment plan, and let the patient know what is that plan so that they can work towards it. That's my plea.
Thank you.
Thank you.
Thank you, Prof.